Well, thank you, Susan, and thank you for herding the troops and getting people settled back in their chairs. I was here in Philadelphia, I guess it would be 10 years ago now, maybe 11 years since that original Future of Nursing meeting. And I am excited and gratified by how much progress I think we've made over the last 10 years, focusing on addressing the recommendations of the Future of Nursing panel back in 2010. And it's a darn good thing that we've made a lot of progress, because the needs of our society and the health of our population has not been stagnant. And while we've made tremendous progress in some areas, we have seen new threats, new challenges, new problems that really weren't on our radar back in 2010. So very timely that we're here. As Susan said, I'm Margaret Flinter. I'm the Senior Vice President and the Clinical Director of the Community Health Center, Inc. and its Weitzman Institute, which is headquartered and delivers care in the state of Connecticut, but works nationally to transform primary care through research, through education and training, and through innovation. Like others that you heard from this morning, I've been at this a long time. I joined my organization when it was a small group, about a dozen people, one hallway, committed to the principle of healthcare as a right and not a privilege. I was the first nurse practitioner, a member of the National Health Service Corps. And today I'm happy to say that nurses govern, lead, practice, serve, research, transform, and improve primary care at every level of the organization, along with the more than 1,000 other staff people in our offices in Connecticut and across the country. It takes all of us, not just one of us or any of us, but I think today we have a particular focus on nursing. But I always want to make sure we're putting this in the context of the big tent in which we practice. And one of our unique roles is to bring other people into that big tent and make sure that they have the opportunity to practice at the top of their education, training, and willingness to serve. So I want to thank that amazing first panel, who I think you'll agree with me, provided tremendous information and motivation and grounding about the work that's being done for our people and for our populations with complex health and social needs. They did an excellent job of laying out the challenges and the imperatives for all of us in healthcare today, but especially nurses, perhaps because of today's focus, to expertly, sensitively, and effectively design and deliver care for individuals and people in the context of a population health focus. And I could actually spend 15 minutes just talking about what we do in my organization in Connecticut and around the country. But I'm the moderator, not a panelist, so I have to be very self-disciplined. So I'm going to appreciate what they have done. And in particular, I want to appreciate, and I noted this when I saw the program, that they made it clear that when we think about this and we think about our charge as our panel to talk about paying for this, we have to maintain a full lifespan approach when we think about who we are talking about when we talk about complex health and social needs. This is not just about one age group. Those with complex health and social needs are the youngest and the most vulnerable of us, to the elders among us, and all points in between. And they are everywhere, as Sherry said, in rural areas. They are in our underserved areas. They are in our urban areas. And the panel before us shares some strategies that have already stood the test of time and have become integrated into many of our care delivery organizations. The Nurse Family Partnership is part of a group of programs that include home visitation that have shown economic benefit, social benefit, intellectual benefit to children and their families. The school nurses, which we heard such a wonderful presentation on, and the school-based health centers, of which my organization operates about 85 in the state of Connecticut, documented evidence of improved scholastic performance, decreased absenteeism from school, and cry out for a greater expansion, the federally qualified health centers and the rural health centers. But we know that these resources are not universally nor equitably distributed, available, and at a scale to meet the needs of all of our populations with complex health and social needs. And payment and payers and incentives can help to drive that change. So as we turn to this panel, we recognize that we have to innovate not just in the delivery of care, but how we pay for it. And we have to ask for the same kind of evidence on the effectiveness of our payment models and strategies as we demand of ourselves in looking at the effectiveness of new care delivery models. They are inextricably interlinked. As nurses across the spectrum of the profession, at all levels of engagement and influence, from organizing and delivering care to research and policy, we understand the value proposition of value-based care, that care which yields a benefit and an outcome that is equal to or greater than the cost of that care. And I think, as some of my friends here know, perennial optimist that I am, you can't do this work without it. This is a time of considerable progress and innovation in how we organize and pay for care for all people, including those that are the subject of our panel today. We are, for sure, increasingly focused on investing in screening for and addressing the social determinants of health. We've always been about looking at the social determinants of health, but we've fallen short in being able to do something about them because none of us can do it alone. It takes changes and payment to do that, like resolving the social determinant of homelessness with housing. And on the train down here yesterday, I was so pleased to read the CMS report on the Support Program for Families and Communities Act, which recognizes that if we're going to treat substance use disorder and opioid use disorder and people do not have stable housing, we will not be effective in our treatment, and therefore how wonderful to see that as a new payment initiative to help provide housing and social supports. We increasingly are taking, and our payers are responding to this, what we call in my organization a wherever you are approach to care, going where the patients are, in their homes, in their schools, in their workplaces, and in congregate settings. And this is extremely important as we talk about reaching our most challenged patients who may be in none of those places and in all of the spaces in between. We're making progress on embracing technology in this care, and technology is our friend, and the payers are responding to this as well, with payment for telemonitoring at home, with new strategies, both electronic and interpersonal, to engage patients and families outside the provider office and in between the visit. We're doing it with access to specialists, no matter how remote or how underserved the community or the patient, via e-consults, and we have seen tremendous progress in the past year with new legislation coming out of the federal government, with Medicare, with legislation in some of our states. I'm proud to say Connecticut, we always call it the land of steady habits, but they were the first ones to pay for e-consults for patients in a community health center setting. And we're seeing increased emphasis on being willing to pay for virtual care for some of today's most vexing problems. And again, and Ellen Marie, I'm not trying to set you up for this, but how pleased we were to see Medicare recognizing that when it comes to substance use disorders and treatment, requiring the patient to get themselves to their practice in order to access virtual care with a specialist may not be the winning strategy, and paying for that care with the home as the originating source of a care is a significant innovation in payment that can help us really address one of our most serious problems. And we're changing how we educate and prepare our current and next generation of healthcare providers to competently embrace those changes. Still too often, that work is not compensated. But we have got to figure out how we change, how we train and educate our providers and their teams in the field today. We have Project ECHO as a strategy, documented, evidence-based, to be highly effective in helping people who, when they were doing their training, were not being trained to manage HIV in the hopes that we're going to end this HIV epidemic in primary care, to address chronic pain, to treat opioid use disorder in primary care. We have Project ECHOs for dealing with complex pediatrics. We have in my organization, we have the country's first ECHO devoted specifically to RNs who do complex care management in the community. These are strategies to increase the capacity of our current workforce. And then there's our future workforce. We've made great progress there too. We have fellowships and residencies for postgraduate nurse practitioners committed to practice as primary care providers in high risk and high need populations. We have dedicated education units for our BSN students, because everybody says RN complex care managers, few have looked at how to train and educate people to this as part of their undergraduate nursing education. And again, it's not just about us. We need to train our behavioral health providers so that we have fully integrated behavioral health and primary care, our medical assistants so they can practice to the full scope of their license, and everybody else who's on that team. But payers and payment models are a driving force for innovation. We have to ask the question, are we investing enough in primary care? Hot off the press, the recently released July 2019 report from the Patient-Centered Primary Care Collaborative and the Graham Center suggests that we are simply not. Compared to our international counterparts, compared to some of our states, a few of our states, like the great state of Minnesota, if anybody's here from Minnesota, that spend more than the average on primary care, and in part, we see an association between that primary care spend, fewer ER visits, fewer total hospitalizations, fewer hospitalizations for ambulatory sensitive conditions. This year, CMMI introduced 5 new voluntary primary care payment and delivery models. I think that that gives emphasis both to how hard all those folks are working in Washington, and we appreciate that, but it also emphasizes how important primary care is in driving change, because primary care is where everybody is, including those with the most complex health and social needs. You know, in my own state of Connecticut, just 4 years ago, only a handful of our more than 100,000 patients that we see annually were enrolled or attributed to what we would call a value-based care arrangement that included payment strategies to focus on complex health and social needs. 4 years later, more than 75% of my patients are enrolled in or attributed to such a plan. And most of those people live under 200% of the federal poverty level, are disproportionately members of racial and ethnic minority groups, have a far higher incidence of chronic disease than the general population. This shift has been driven largely by the public payer, by Medicaid through its Patient-Centered Medical Home Plus initiative, with an intensive focus on and payment for identifying and specifically addressing the already high-cost, high-need, high-risk patients. But I think what they've gotten right in Connecticut, and I think we will see more of this around the country, is they're equally focused on the prevention and the early detection of those individuals who we know will someday be the high complexity, high need, high cost patient. Those individuals with unmet or undiagnosed developmental delay, behavioral health disorders, substance abuse and trauma issues, those lacking the social, family, and community supports to thrive, and those whose unique circumstances of health will require intensive care and effort, even if all their health care and social needs will be met. And Medicaid is not alone. They are joined in a somewhat dizzying array of Medicare Advantage plans, private commercial insurances, ACOs, Medicare, and because we are a community health center, we have to focus on those whose payment method, their only payment method, is what in their own pocket and in their wallet, the uninsured and the uninsurable. So what was once innovative now has an evidence base, and where there's an evidence base, payers must follow. Investing more in integrated and interdisciplinary primary care teams. Investing in care management as close as possible to where the patient and the family live and where they receive care and with their medical team. Managing that transition between hospital and home, which we have a long track record with. Identifying those most at risk, at highest need, and most likely to benefit, and having specific interventions for them and paying for it. Engaging with our community partners and bringing them into our big tent as well. We have to remain mindful that it is not just the care that we're paying for, it's the context of that care, the ability of a practice to change and adapt to new ways and to pay for them, to hire and retain additional staff that were not on our teams before, the pharmacists, the community health workers, and of course the behavioral health providers. It's the infrastructure that we need to pay for, the facility redesign, and the offstage players who deliver up to us the just-in-time data that we need. All of this needs to align. We need to remove barriers, speed up innovation, incent and reward excellence in care and value, and ensure that the point of all this, a healthy, just society in which people and families get what they need to achieve or maintain their best health, is a reality. Today, we have expert panelists who are designing, implementing, studying, and encoding in our healthcare system new payment models and policies, and I am delighted and honored to introduce them to you. We're going to start with Dr. Ella Marie Whalen, the Chief Population Health Officer for the Center of Medicaid and CHIP Services, who will speak first on the federal perspective on paying for those with complex health and social needs. Next, after Dr. Whalen, we will hear the state perspective on payment for those with complex health and social needs from Carol Johnson, the Commissioner of the State of New Jersey, Department of Health Services. We're so delighted that you're here. We've followed your work there in New Jersey. And our third panelist will speak from the local and regional perspective on payment. My great pleasure to introduce to you Terry Sterling, the Executive Vice President for Strategic Initiatives from Our Lady of the Lake RMC. I want to thank all of our panelists in advance. I know they will have you on the edge of your seats as you hear about payment. In the hands of some, a dry topic. In the hands of the panelists that's been assigned here today, nothing could be farther from the truth. Dr. Whalen.